Welcome back to AJIC Science and Practice. I want to start today with something that I think a lot of IPs feel, but don't always say out loud. Nobody trained us to be leaders.
That's right, Nikki. You get your CIC, you learn the surveillance, you learn the regs, and then one day someone puts you in a room with hospital administration and expects you to just hold your own.
Yep, they sure do. And you figure it out, or you don't. But there's no real roadmap.
Which is exactly why today's article hit me, because it's actually asking, what does leadership look like for IPs who have intentionally developed it? What are they doing? What are they up against? And does formal credentialing actually move the needle?
Yeah, and we have the people who did that research here to talk us through it. And we are so excited to welcome our guests today. We are excited to welcome Dr. Kayla Ruch. She's a clinical specialist in infection prevention and control at BD and an epidemiologist with more than 8 years of IP experience across acute care, long-term care, and public health. She has led statewide education initiatives, and she's published peer-reviewed research, presented nationally on IP and workforce development.
And she's also on the APIC Houston chapter board of directors and serves as a reviewer for multiple peer-reviewed journals. She's very much embedded in the professional community she's studying, which I think actually adds something to this work.
I would agree with that, yep. And joining her is Dr. Al Mohajer, professor of medicine at Baylor College of Medicine, national leader in infectious disease, infection prevention, antimicrobial stewardship, and healthcare epidemiology. He currently serves as CBIC president-elect and has leadership roles across CBIC, IDSA, SHE, and APIC.
So between the two of them, we've got the workforce development lens and the credentialing governance lens in the same conversation. Dr. Ruch, Dr. Al Mohajer, welcome to the show. We're so glad to have you both here with us.
Thank you for having us.
Thank you for having us.
So let's get right into it. The paper, and I love what it stands for, is called Leadership Experiences of Infection Prevention and Control Professionals. Findings from the Leadership Evaluation and Development for Infection Preventionists, or LEAD IP study. And it is the first study of its kind to actually look at the lived leadership experiences of IPs who hold the AL-CIP, or the Advanced Leadership Certification in Infection Prevention and Control.
And if you're not familiar, it's a portfolio-based credential from CBIC that evaluates advanced leadership, strategic vision, mentorship, advocacy, systems improvement. So it's not a written exam. You have to actually demonstrate that you've done the work.
The study used a nested cohort design, which means that they pulled secondary data from all AL-CIP applicants across two 2025 certification cycles, which was over 250 people total. And then a nested group of 30 certified professionals sat for 60-minute qualitative interviews.
Yeah, and the analysis used Braun and Clark's inductive thematic analysis, meaning they let the themes come from the data rather than going in with a predetermined framework. And 7 themes emerged.
7. And honestly, I found myself nodding at almost all of them. The first was this shift from task-based to systems-level thinking, which I think is the defining leap in any IP's leadership development. You stop fixing individual problems and start asking why the problem keeps happening.
Yeah, and the second was data literacy, using dashboards, audits, improvement frameworks to actually make the case to leadership. And one participant put it really well: data drives the conversations now, and dashboards help tell the story.
Yeah, themes 3 through 6 covered communication, psychological safety, structural barriers like staffing, time, competing priorities, intentional inclusion of underrepresented teams like EVS and outpatient settings, and proactive risk stewardship.
Yeah, there were some good APIC, at National APIC, there were some good presentations on that. And the 7th theme is the one that I think is the most interesting for where our field is right now, which is leadership identity formation. So the credential itself changed how people saw themselves, not just as IPs, but as leaders.
Which is not a small thing.
No, it's not. So let's bring this to the ground level for a second. For someone who is maybe a newer IP or someone who's never really thought about formal leadership development, what is the AL-CIP and who is it actually for? And Dr. Al Mohajer, I'm going to let you answer that one if you don't mind.
Thank you. So, at the simplest level, the AL-CIP is CIBIC's advanced portfolio-based certification for professionals who can demonstrate leadership and measurable impact in infection prevention and control. So it's different from a knowledge exam, where candidates submit written rationales and evidence that show how they have led change, improved system, advocates for infection prevention and control, built inclusive teams, and contributed to professional development. So an active CIC or long-term CIP is required, and CIBIC recommends roughly 7 to 10 years of advanced practice and professional impact. But the key point here is that it's not tied to a particular title. You don't have to be a vice president or a system director. It's really for the infection preventionist whose work has moved from I carry the program to I help shape the program, influence the organization, develop others. So the ALCIP recognizes leadership that you can demonstrate, not merely leadership that you can claim.
And in plain terms, what's the difference between an IP who has strong leadership skills and one who doesn't? What does that actually look like in practice in the building on a regular day?
I don't think the difference is that one person knows the regulations and the other does not. So both may be technically excellent. The difference is how they apply that expertise and how broadly they frame the problem. So let's say on a regular Tuesday, a task force IP may identify have an increase in infection, complete the line list, you review compliance, you remind staff about the policy. And those are necessary steps. A strong leader also asks what in the workflow, what in the staffing, the environment, the communication, the accountability structure that's repeatedly creating the risk. So here they use the data to tell a story that executives and frontline teams can act on, bring the right disciplines into the discussion, creating enough psychological safety for people to raise concerns early, and also develop a measurable plan instead of just issuing another reminder. So here technical expertise help identify and respond to the problem, and leadership helps the organization change the system that produced it.
Yeah. And speaking, okay, so you've kind of gone over like how the leader works and how kind of the frontline IP works. And the study found that even though among those certified advanced leaders, there are structural barriers, that was a major theme. So maybe not enough time, not enough staff, competing priorities. So for someone on the floor who might hear that and think that's just the job, why does it matter that we name this as a barrier just rather than accepting it?
That's a really excellent question. Naming these barriers matter because we cannot improve a system we refuse to describe accurately. So the fact that even advanced certified leaders reported staffing shortages, competing priorities, inadequate protected time tells us that this is not simply an individual resilience problem. So when we say that this is just the job, we normalize a model that depends on heroics. The IPs remain trapped in a reactive cycle with responding to the immediate infection, deadlines, or regulatory need, with too little time for doing proactive risk assessment for their education, relationship building, and system improvement. So when we name the barrier, it's not about making an excuse. It's about converting a vague frustration into organizational risk that can be measured and addressed by staffing models like the APEX staffing models, protected time, data support, governance, and clear priorities. So the IP here is accountable for professional practice, but the organization is the one that's accountable for creating the conditions in which prevention can really succeed.
I just want to say, wow, wouldn't that be lovely if all of those conditions existed for us? Just going to throw that out there. Yes.
Absolutely.
So let's talk about the study design. The interviews weren't audio recorded, which is acknowledged as a limitation. Can you walk us through how you standardize the note-taking process across the interviews and how confident you are in the analytic fidelity of the transcripts that came out of that since they weren't recorded?
That's a great question, and I'll go ahead and take that. So one of the ways that we wanted to help with transparency was not to record some of the interviews. Some individuals were concerned that maybe their responses might get back to leadership, especially when talking about barriers like of having protected time, resources, and support to move that shift to a leadership and being conscious of leadership development. So one thing that we did was we had one person, myself, do all the interviews for the 30 different individuals that participated so that there was standard question asking and note taking, along with keeping it very open-ended and asking clarified questions in a way that we're not leading or biased an individual. So if there was confusion on language or terminology, I could answer in a non-leading or biased way, trying to push the participants to give one answer versus another. Since originally I thought this would be a US-based study, but it actually turned into an international study with 4 different countries participating in infection prevention leadership. So we wanted to make sure that we were understanding different themes, because a lot of us experience the same issues being in an IP and being a leader in IP, but due to language and cultural and regional differences, we might call things different. So that was why it was a very conversation but structured outline of what we were looking for participants, and then asking them in a standard way, and then making sure that there wasn't biased or leading, pushing them to produce a certain answer.
That's such a great way of doing it, because I think a lot of times when we're doing different things similar to this, collecting data, you have to account for some inter-rater reliability among the people doing the surveying. And so to have one person do it that takes away like that requirement, which is really awesome. And also awesome that this was an international study. How cool is that?
Exactly. And being able to, with my background, being in acute care, long-term, skilled, and public health, seeing the different settings, since the cohort involved all IP leaders from the different settings. So it wasn't just acute care systems. We had public health, we had small hospitals, we had IPs from outpatient clinics. Being able to have that experience and kind of knowing what they were going through, that we were able to design questions that were broad but specific enough to encompass all settings that experience IP strengths, challenges, and barriers.
I think that's important because sometimes we get stuck in the acute care lens, specifically the short-term acute care lens. So it's nice to see a broad application of this. And one of the limitations that you named directly is the potential for social desirability bias. So people who just earned a credential, talking about how meaningful that credential was. How do you think about interpreting the findings through that lens, and what would you need to see in future research to feel more confident that what you're measuring is real leadership development rather than just credential enthusiasm?
That is an excellent question, Nikki. I think one thing, it was nice to see that there wasn't a complete 100% shift of the enthusiasm for credentialing. There was a lot of people excited, But one of the questions of what does this credentialing mean and how you're going to apply it, some individuals weren't quite sure because it was such a new process, or they just obtained it. So there was transparency with that. I think a great follow-up question would maybe be a year or 2 years after receiving the credentialing. How has this been helpful? Do you think it has advanced your career as expected? Have you used it the ways that you plan to use it? Or has there been other opportunities that maybe you didn't anticipate? But now that you have this credentialing, it has opened up additional doors for you. So I think a long-term follow-up question can really help demonstrate the usefulness of the credentialing and how they've applied it. One of the questions and kind of feedback that we received from participants is that a lot of people were excited and they were hoping that it would put them into a new leadership bucket, new opportunities, teaching, research, education, giving back to the IP community. So it would be interesting to see if that leadership credentialing really set you apart from the other applicants and you got into more of those roles, or maybe not the direct leadership roles, but indirect leadership roles of mentoring, being part of committees, being asked to come give talks, presentations. You have felt more competent in submitting your abstracts for conferences and different discussions.
Yeah, the intentional inclusivity theme really stood out as well, specifically the effort to bring EVS, outpatient clinics, behavioral health into IPC decision making. And that's an area where I think a lot of IPs know it matters, but they struggle to operationalize it. What did the certified leaders in this study actually describe doing, like not just valuing inclusion, but like practicing it?
Yeah, that's exactly why I wanted to ask it. There's been a lot of push for, inclusivity and being an inclusion leader and looking at ways to get continuing education for inclusion and leadership. But what does that exactly look like? So when talking with participants, a lot of their feedback was making sure everyone had a voice, pulling them up with them, inviting people to meetings that maybe that are left off or that are late to the game. We see that a lot as IP. Sometimes we're an afterthought. So being the leader, that's also making sure everyone's there at the table to really help you move forward was a big thing that a lot of people were practicing. Also with inclusivity, they were talking about level of transparency and good communication. So to be inclusive, it was also setting goals, timelines, objectives, and talking about it as a team and making sure everyone is heard, everyone agrees with the measures, and that it's a very comprehensive plan, especially when we're doing our risk assessment, our policies and procedures. Sometimes IP, we think that we know best, or that in a perfect world, we would like, these 10 things, like IP wants these 10 initiatives. But when you talk to other individuals and you're having that inclusive conversations where everyone feels the ability to speak up, they can say that's great on paper, but actually to implement it and to operationalize it, it's going to fail because of X, Y, and Z. So then you can have a better conversation of, okay, well, those are what some of the challenges are. Where can we meet halfway? And so that we still get that IP infection control things that we would like all the staffing to do, but then also that it's not such a barrier or we have hesitant or pushback from implementing because we're asking them to change their process.
So the first thing that I keep coming back to is that leadership identity piece, and that's the idea that certification didn't just validate what the IPs already know, it changes how they understood themselves professionally. So that feels pretty significant for a field where, we just talked about this. It's a field where a lot of people came in through a side door, spent years proving that they belong at the table. So what does it mean for the IPC workforce if we can actually formalize that identity shift?
No, I think this is significant because many IPs have been doing leadership work for years without that they necessarily been naming themselves as leaders. So people right now enter the field from nursing, lab science, public health, any other pathways, and their leadership development is often, say, informal. They develop it through experience, variable mentorship, and trial and error. The portfolio process asks someone, let's step back, let's document the impact of the work, recognize the common thread across years of practice, and the credential does not manufacture a leader. It's really highlight an existing leadership and make it more visible to the individual, to the employer, and to the profession. So, for the individual, that can strengthen confidence and clarify career direction. For organizations, it can help identify mentors, successors, people ready for a broader responsibility. And for the profession, it helps us build a deliberate leadership pipeline rather than just hoping people simply figure it out. So one credential should not be the only pathway, but it's a formal recognition that can make leadership development, let's say, more intentional, accessible, and also valued.
And the second thing we come back to is a broader workforce question. The conclusion calls for integrating leadership development into structured onboarding, succession planning, and graduate level curricula. That's a big ask in a field without a standardized training pathway to begin with. Where do you think the most realistic entry point is, and who needs to be at the table to make that happen?
It is a big ask. I feel like it is a big ask, but with the credentialing process of kind of establishing that IPs are leaders, the next step is, well, they're IP leaders. How do we give them the support? Some facilities, especially larger hospital system, they have leadership development more for their managers and directors. But usually IP is left out of that conversation, especially when we're doing internal leadership within organizations. They think that you need that manager or director title, but a lot of IP leaders are not holding those titles because there's only, in a healthcare system, there's only one director, one manager, but each IP leads with informal leadership. We are heading up tasks, we are doing protocols, we have different projects, we are collaborating on different initiatives, we're working with special groups. We hold a lot of that leadership, but informally. So maybe one way is that when facilities and organizations are looking at leadership development to include IPs in that, not just their nursing leaders, not just their individuals that hold that title, but also kind of elevating them and giving them the internal leadership training. Another thing is to talk about within the department of giving newer IPs in that proficient IP, that 5 to 7 years, more leadership support, making sure that you're training them and mentoring them as the manager and director of leading initiatives, giving them chance to run meetings, giving them support, not only doing feedback on one-on-one job performance, but also integrating that mentee-mentor leadership level as well, so that we are helping build the new IP workforce. A lot of us know that we're going to see a huge decline of IPs leaving the workforce because many individuals are getting ready to retire. In a lot of the tasks that the managers and director levels IPs do, they need to be training the next level of IP, that proficient IP of, how to set up the infection control plan. What does that look like? How do you handle that data? How do you set metrics? How do you give this data to the executive suite? Or if you have to go to the hospital board and you have to go to the medical committee, how do you have those conversations? Let them come watch you present. Do a lot of that mentoring and just not assuming that they have it, but being very intentional with your time and setting up either direct or indirect pathways for IPs to gain leadership experience and support.
My first impression of what infection prevention was as a bedside nurse, I was excited. The role opened up. I was very excited. to help prevent CAUTIs and CLABSIs and C. diff. That's what I thought infection prevention was, and I was really excited to get involved in antimicrobial stewardship.
Not the hand hygiene police, Nikki?
Not excited about that. Still one of my favorite parts of this entire job. And that was my impression of infection prevention. And I got into it, and then I start realizing that there's so many more exciting tasks that I get to be a part of and get to help develop certain protocols and procedures and do all this and that. And then I kind of consider that the second phase. And then the third phase, and I am definitely boiling all of this down. There's a lot more phases, but then it's almost burnout, because as we've talked about, you're trying to get this seat at the table, and I don't understand why everybody doesn't understand why my role isn't so important. So this really does help the infection preventionist who is new kind of understand that there's not a straight path. And like you said, that there's that mentorship piece, and there's a lot. This is a very rich conversation. I might be a little biased though. So what struck me the most is that the study was essentially saying that IP leadership is real. It's complex, it's teachable, it matters for patient safety, which is where I think all of us started from. We just wanted what was best for the patients. So now we finally have the data to back that up.
Agreed. And for our listeners, whether you're thinking about pursuing the AL-CIP yourself, or you're just trying to figure out how to walk into that next administrative meeting with some confidence, this article is definitely worth the read.
Yeah, thank you both so much for being here and doing this work. And I'd love to hear what you guys kind of have to say to round everything out. And
thank you. Thank you so much for inviting us. Hope more people can learn about the Advanced Leadership Certificate Infection Prevention and how it can help maybe reshape not just their career growth, but also it can help the organization see really the importance of leadership in this role.
I thought one thing that was also interesting when I was interviewing participants is that many individuals said that they didn't really see themselves as a leader. So this really kind of helped them feel more comfortable and confident. As IP, as what we've kind of discussed, it's not just part of the job. We have a lot of initiatives that we're doing. Like Nikki mentioned, that sometimes when we get into IP, we think it's maybe the hand hygiene police, which we're not, but that is a part of it. It's the number one way to reduce healthcare acquired infections. But we sit on antimicrobialship, we do process improvement, we do visitation, we do risk assessment, we're collaborating with local health, we are doing HAI reduction committees initiatives, we're doing construction, pharmacy, compounding, medication, safety, kind of anything and everything, which people think that IP is this very narrow field, but we do a lot and touch a lot and work with everyone in our hospitals. So being able to know how to have that conversation, to use what language, hold presence, get that meeting, get that support for your initiative. That's really important, especially that we're doing a lot. You might have great ideas as IP, but maybe you don't know how to present it. You're not comfortable with data. You're like, we're having people with this. I have this great plan, but I don't know how to put it together. So definitely having mentorship, leadership, asking another IP, and just kind of giving you an idea of what are some things that I could work on to kind of set myself apart and really show that I'm a leader, even without that formal title of manager or director.
Absolutely. And on that note, apparently the path to advanced IPC leadership involves systems thinking, data literacy, psychological safety, and proactive risk management.
Yeah, yep. So it's everything that they did not cover in orientation.
But at least now there's a credential for it.
Yep. Well, thank you guys again for being here with us. This is a wrap up of AHACP Science and Practice. Like I say, that's a wrap.
Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Jean Brandt at AGIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Althan and Carolyn Schneer. To hear other AGIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, agicscienceintopractice.org. That's AJIC scienceintopractice.org.